Welcome back to the PFC Podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC Podcast. This is Dennis, and today I am with my favorite ICU doc. How you doing, Doc?
Good, Dennis.
Happy New Year.
Thank you. Happy New Year to you too, and everybody listening.
So today I would like to talk about pneumothorax and potentially hemothorax, and when exactly do we need to start treating them. A couple podcasts ago, we talked about tension. That makes 100% sense. You have pressure in the chest. It's affecting hemodynamics. Now it becomes a medical emergency. You need to treat it now. However, I can see pneumothorax potentially becoming an emergency in itself, because not because of pressure loss, but because I'm losing SpO2. And I don't necessarily have the ability to just increase the amount of oxygen I'm giving to the patient.
Right.
So maybe if you wouldn't mind, can you kind of show me where exactly is that borderline between tension, pneumothoraces, and just a hemothorax?
Well, the borderline with any tension physiology, whether it is due to air outside the lung in the pleural space, or blood or other fluid in the pleural space, is when blood return to the heart is impaired, typically the right ventricle, because the right ventricle is weaker. It's a weaker muscle than the left ventricle, more easily compressed. And so when your preload drops, you can't generate enough cardiac output, and your blood pressure drops, and you enter what's called an obstructive shock. Something outside the heart is obstructing its ability either to circulate blood out, as in the case of a massive pulmonary embolism, or fill with blood, as in the case of any type of tension physiology around the lung. So that's the borderline. If your blood pressure is stable, your vital signs are otherwise stable, and you have air around the lung or blood around the lung, you do not have tension physiology.
Okay, that sounds perfect. So we're talking about everything short of that.
Correct.
When would a hemothorax actually become dangerous? Because there are people walking around with hemothoraces that are not treated at all.
Hemothoraces or pneumothoraces?
Or I'm sorry, pneumothoraces.
The literature talks about medically managing or observing pneumothoraces that are less than 30% of the area of one of the thoracic cavities. So the left side with the left upper and lower lobe, and the right side with the right upper, middle, and lower lobe. So 30% or less in a stable patient, in an otherwise stable patient, can be observed and encouraged to resolve on its own. The other, one of the things that would be unstable would be obviously oxygenation. Somebody with healthy lungs is going to tolerate losing, 30%, 15%. So 30% on one side, averaged over two, is 15% of their lung volume. Somebody with, healthy lungs is going to tolerate losing that amount of lung volume a whole lot easier than somebody with sick lungs, either chronically sick with something like, chronic obstructive pulmonary disease or lung cancer, or acutely with pulmonary edema, pneumonia, ARDS.
Okay, that makes sense. So, and I imagine generally, we're talking a lot about trauma. I would imagine there are spontaneous pneumothoraces that happen on occasion. But at least what I imagine, mostly pneumothoraces are caused by trauma. Is that true?
In general, yes, although we saw a ton in COVID especially with the first two variants of the disease, the Alpha and the Delta variant, which had a much higher rate of hospitalization and ICU admissions, caused a lot of lung scarring. And we call them blebs, basically air pockets in the lungs where the lung tissue is destroyed and just an empty airspace remains. And they would pop and cause pneumothoraces. And, it probably in the patients that we saw in the ECMO unit, it wasn't quite 50%, but it probably wasn't far below it.
Okay. Now, is that because, I imagine also early on, we were very aggressive with vent management and.
Yeah, so barotrauma from vent management of these patients with COVID pneumonia, which causes a lot of lung scarring and makes the lungs really, really fragile, is part of it as well. And that was, for sure part of it in our patients, because most of our patients, pretty much 100% of our patients on ECMO were also ventilated. And so even
that makes 100% sense.
Yeah, even with really gentle ventilator settings, it could still happen.
Okay. And I would imagine similar to that would be something like blast lung or something like that. And
yep,
in the population I'm thinking of anyway.
Yeah, blast lung, gunshot wound to the lung, blunt force trauma from vehicle accidents or falls. And then very rarely you get spontaneous pneumothoraces, typically in people with something called Marfan syndrome, which is very, very tall, very thin body habitus, but it's a whole syndrome. And they are prone to spontaneous pneumothoraces as well.
Okay. So kind of continuing that kind of trauma, at least mindset anyway.
Mm-hmm.
I imagine, you're talking about somebody with healthy lungs, they can compensate very well or fairly well with the pneumothoraces, but when you add on top of trauma, blood loss, maybe narcotics that are depressing respiratory drive,
Mm-hmm.
I imagine all those things kind of add up, making the situation a little bit worse.
Right, exactly. A traumatic pneumothorax implies damage to the thorax, to the chest cavity, and the lungs, which lie within the chest cavity, and it's pretty rare that some traumatic event that's significant enough to cause a pneumothorax isn't going to cause some damage to the alveoli as well, and that may not be manifest right away. If it's a blast or a fall or a blunt force trauma, you could have a contusion, like a bruise that develops over time, that basically causes pulmonary edema, fluid in the alveoli of the lungs, the small air spaces, and as that develops, their ability to tolerate the drop in lung surface area within pneumothorax could get worse.
Yeah, that makes absolute sense.
You think about it that, if you have a patient who has a pneumothorax from trauma, and over time, as you're watching them, their oxygenation gets worse, their respiratory rate goes up, their heart rate goes up, but their blood pressure stays stable, it's probably an oxygenation problem and a lung damage problem. And they're not, or the pneumothorax is compressing more lung, right? It's gone from 10 to 15 to 20 to maybe, potentially dropping most of the lung without causing tension. If you have all those things and the blood pressure drops, then you have to think it's tension.
Okay. Yep. So kind of going along, okay, I recognize this patient's just from MOI, done March. Okay, I found an injury, or I at least suspect he's got an injury, long potential for development of pneumothoraces or potentially hemothoraces.
Mm-hmm.
When I assess with my stethoscope, I keep hearing his lung.
Mm-hmm.
So, but my SpO2 is changing. His respiratory rate keeps climbing.
Mm-hmm.
His heart rate keeps climbing. And I keep wanting to give him more narcotics because it just seems like he's just in pain.
Mm-hmm.
So I guess, how do I kind of cipher through this situation and not just convince myself that since I can hear as long, that there's nothing actually wrong?
Well, that's a good question. It's tough to diagnose a pneumothorax with just a stethoscope because you can get reflected lung sounds. It has to be pretty big before you have an area of the chest that's dull to percussion and has absent or hyperresonant breath sounds, or absent breath sounds. I'm sorry. The gold standard is actually an ultrasound. It's not a chest X-ray, because an ultrasound is going to let you look for other stuff, right? It'll not only show that you have a pneumothorax, but if that's due to bleeding and you have a hemothorax, you'll see a collection of blood. If you've got concurrent pulmonary edema, you'll see B lines. If you've got sort of a mixed picture of atelectasis and ARDS, you'll see consolidations. So with your patient that you describe in your stethoscope, I would probably first treat his pain and see if things improve with that, as long as he's stable enough. That's one of my favorite sayings, is perfection is the enemy of good enough, and stable enough is a great goal, especially in an austere setting. If he's unstable, if he's coding and you have mechanisms, then you may just have to empirically, and being prepared that if you do and it's not a pneumothorax, you just gave him one, and so now you've got to place a chest tube.
Right. And so, I think that latter part, you were essentially describing attention physiology,
Right.
which, you have to act immediately.
Right.
Now, at least a lot of people that I train with and that I train, essentially it's MOI plus one. He has a hole in his chest from something, and he's breathing fast, or he's got a hole in his chest and his SpO2 isn't, 98% or higher.
Okay.
Is it, what would be your medical opinion about just using that criteria alone to go ahead and start sending needles?
Again, unless you're prepared to treat a pneumothorax that you create with your empiric needle, I would probably hold off, because there are other reasons for hypoxia, and it depends. It's a matter of degree, right? If the SpO2 is 85%, then again, that's probably good enough. If it's 65%, that kind of gets your attention. Respiratory rate is one of the first things that's elevated in trauma for all sorts of reasons: pain, anxiety, shock, blood loss. My preference is establish some trends, do some non-invasive things, to treat things that, are on the differential diagnosis that can be treated non-invasively, as long as the patient's giving you time, to respond to all of these and not crashing and burning. If they're crashing and burning, it's a different conversation. But I'm going to assume that your patient is, looks sick, but isn't, urgently unstable, where you just got to throw the kitchen sink at them.
Right. No. At least from what my understanding and what little experience I have, these pneumothoraces, they don't really develop that fast that you have to jump in off the top rope on the X to start treating.
And with all of our pneumothoraces in COVID, only a tiny percentage of them got chest tubes. Most of them we treated medically, and tried to get the lungs to heal, and the pneumothorax to resolve themselves.
Okay. So, you said you treated them medically. So maybe if you wouldn't mind go into what exactly does that mean?
Well, you want to minimize positive pressure ventilation as much as you can, because if you've got a hole in the lung that's communicating with the pleural space, pushing more pressure, positive pressure into the lung is going to, just push more air through that hole into the pleural space and worsen your pneumothorax. So if you're not on positive pressure ventilation, try not to start it. If you are, try to reduce the pressure as much as possible. If you can switch to a mode where the patient's breathing spontaneously and avoid giving him extra breaths, do that. If you need to increase your oxygenation, these are patients that I would prone first before I increase their PEEP, because PEEP's going to make the pressure worse and pneumothorax worse. Proning isn't going to trouble any of that.
Okay. So I guess the pressure you're talking about reducing, is that the PEEP? Is that the PIP? Is that everything?
Yes. I want to give them the smallest tidal volume or pressure support, whichever mode you're using to deliver the breath, and the lowest PEEP that will give me a good enough oxygenation. And there I'm thinking, between 85 and 88%. Certainly if you're in the 90s, stop. If you're in the 90s and you're on no supplemental oxygen, you have to question whether they need to be an event at all. So good enough oxygenation and then a good enough end tidal CO2. I would settle for something in the high 40s to 50.
Okay.
Probably high 40s, since it runs a little bit lower than the R2, but still, I would settle for a good enough SpO2 and a good enough end tidal CO2 at the lowest pressures possible, both in terms of PIP and PEEP.
Okay. And so you mentioned 85%. So let's say, we prone the guy, or whatever other positioning we can come up with, best of our knowledge. We've reduced the amount of pressure that we're giving this guy to the best of our abilities.
Mm-hmm.
And we're still not really hitting goals. We've even starting up the Soros that we found, and we're hitting them at 3 liters a minute, which is the max.
Okay.
So, it's not attention, but should I start treating the actual pneumothoraces?
At that point, I would, right? Because, you've got a physiologically significant pneumothorax, not from a hemodynamic standpoint, but from an oxygenation standpoint. And that's an indication to ideally put in a chest tube.
Okay. Is this something that's an emergent thing? Or, obviously it's going to depend on how fast did he go from 95 to now below 85, but something that I need to drop a needle and then maybe do a finger thoracotomy and then progress into a chest tube? Or can I just kind of prepare to do a chest tube and just get it over with?
Again, it really depends on your rate of decline. If it's been over hours, I would say you have time to do a chest tube. If it's, minutes and he's gone from, 92 to 85 to 80 to 75 as you're standing there, you probably don't have too long before the hypoxia is severe enough that he goes into cardiac arrest. And so in that case, either emergent finger thoracostomy or a needle or both. Before you probably don't have time to get a chest tube in.
Okay. Just in your experience, maybe I asked this again and I'm forgetting it, blanking about it. How fast is this normal progression? Say, a gunshot wound or a car accident, is this, we talking minutes, we talking hours, we talking days?
There's no normal.
No normal.
There's no normal. Some people will tank before your eyes, in the scenario I just described, and some people will, develop a pneumothorax a day later, and it remains small. And some people will develop a slowly progressive one that worsens over 24 to 48 hours. There is no normal pattern, which is why you just really need to be vigilant and then confident in your assessment, and confident in your ability to intervene, before it's too late. It's tough. You've got to be Goldilocks, right?
Right.
We don't want to intervene too early and do a procedure and cause harm, especially if there's not a pneumothorax and you're doing a procedure that gives one. But you also don't want to be too late and you're putting in the chest tube what people are doing chest compressions because they've gone into PEA arrest. They braided down to 30 and gone into PEA arrest because their oxygen saturation is like 45.
So if you had to err on one side or the other, which side would you want history to judge you?
I prefer not to err.
Oh, yes, of course. However, you're still human, just like we all are. So would you rather be over aggressive and known to do things early, or would you rather be the guy
I'd probably err on the side of caution and then increase my vigilance. I'd probably watch. That's generally, I would err on the side of caution, not do a procedure unless the patient demonstrated a worsening trend, but I would increase my vigilance. And I would, the other thing I would do is I would prep to do that procedure, right? I would have everything at the bedside, and we do this all the time in the ICU, right? If we think a patient's going to, become unstable or be unstable when they arrive, we'll have all the cardiovascular drugs to put in the room waiting for the patient. If I think they're going to need an airway, we'll have, RSI drugs in the room. And, sometimes they just go back in the medication cabinet. But, a patient like this is, a patient with a pneumothorax who's rock solid stable, even though their pneumothorax looks like a crescent, say you have a chest x-ray and it looks like a 2-inch wide crescent over the top of their right lung, they're not as much of a risk as a patient who, has a pneumothorax that you've diagnosed on ultrasound and it's just clinically deteriorating, after you've eliminated all of the reasons for their deterioration. Are they bleeding? For instance, being a big one in trauma.
Yeah, absolutely. So I also hear a lot of needle decompression is diagnostic and therapeutic at the same time. So,
or harmful
as well.
Right. So it's either diagnostic and therapeutic, or it causes an iatrogenic injury, which isn't trivial.
Right.
And God forbid you don't, and please don't hit an intercostal artery as it's going in, because then you really have caused an injury. Then not only do you have a pneumothorax, but you have a hemothorax, and intercostal arteries can bleed like stink.
Oh yeah. And also that 3¼ inch needle is more than capable of hitting their heart as well.
Yeah, don't do that, or their liver if you get it too low, but hopefully you're going up high in midline like you're supposed to.
Right. So these things are definitely not benign at all. Well, I got to be honest. I think we nailed pneumothorax. So let's I think also very real. I think it's very realistic to say that rarely are they one or the other, hemothorax or a pneumothorax. I would imagine generally they're a combination of both. Mm-hmm. So, when do I need to, are there any different considerations when it comes to a hemothorax? Because I would imagine that blood is going to coagulate.
Correct. Which can be a good thing.
Okay.
Because, let's say you're bleeding into your thoracic cavity, from a vessel that's small enough that increasing the pressure on the vessel will actually tamponade off the bleed. Then at a certain size of your hemothorax and a certain pressure associated with that size, your bleeding may actually stop. And it'll look terrible on ultrasound, it'll look terrible on chest x-ray, but if you're not in tension physiology, just leave it there, and essentially you've stopped the bleed in the lung and let the surgeon scoop all that out in a controlled situation. Where you have to worry is if you have a bleed like an intercostal artery or several intercostal arteries that really aren't amenable to compression, that bleed is just going to continue to get bigger. You will eventually develop a tension hemothorax. The tricky part there is that when you do your finger thoracostomy to relieve the tension hemothorax, and these usually are these usually happen faster and are more urgent, and there's more urgency. Then, that internal hemorrhage is going to become an external hemorrhage, and all that blood is lost, and your patient's going to be not only in obstructive shock, which you relieve, now they're in hypovolemic shock from hemorrhage. So you really need to be able to resuscitate them as you're relieving the tension.
Okay. So one of the kind of the debates that we have as instructors, because we're nerds, is, do I relieve the hemothorax, or do I get access and start sending blood? Which one comes first, the chicken or the egg?
It depends on how close the guy is to dying. If, like I said, if he's in profound shock, from obstructive shock, you need to relieve that first. You need to treat the cause of shock that's going to kill him first.
Okay.
And so if that is, and the thing is, the other thing with ultrasound is, not only can you diagnose the presence of a pneumothorax or of a hemothorax, but you can also observe the effect of it on the heart, right? You can see abnormal relaxation of the right ventricle, of the right atrium, or God forbid the left ventricle if it's bad enough. You can see that it looks squished and it's not fully relaxing. You may want to study this and get some films of it so you know what it looks like. But it's pretty easy if you can get a picture of the heart to see, to use the imaging of the heart as confirmation that you're in tension physiology.
Okay. Nice.
Very similar to what we would do with tamponade physiology, which is the last form of obstructive shock, where something outside the heart. So if that's the case, I would relieve the tension first, because you probably have seconds until they arrest. And then, and you don't need to relieve it all, right? Like, you can put your finger in, get a few hundred cc's of blood out, and take your finger out and cover it with a sealed, with a dressing. And the hemodynamics will improve. And then you can get your line in, or your IO. And if you can't get a line because you can't see the veins because they're hypovolemic already, and start your transfusing. And then at least you can get blood going if you have to relieve the tension again.
Right. I think ideally is you've cross-trained your teammates so that these things can happen simultaneously. The medic relieves the tension, the helper gets an IO or is able to get some kind of venous access.
Right. And if you're in a team with two medics, then it's easy to divide the work, right? Somebody's working on access where the other person's working on the thoracostomy and relieving that. That's not a patient, unless you're someplace where you've got a surgeon close. That's probably not a patient where I would put a chest tube in, but I would clamp it. I would have a way to clamp it.
Okay.
Because you don't want to leave it open to drain, and then the guy just exsanguinates from his chest tube faster than you can resuscitate him.
Okay, I understand that. Now, at least my thought was, if I can evacuate the chest and get the lungs inflated again, then that also will stop being inside the chest. Has that been your experience?
No, a big enough artery is going to bleed until somebody, until some surgeon fixes it.
Okay.
Yeah. Sadly.
Yes. I was hoping you're going to say you're correct, Dennis.
No, I sat on a pulmonary artery injury post-op. It happened intraoperatively, but he came out and wound up having a pulmonary artery injury during the surgery, and was closed up, and basically resuscitated him for several hours until we could get an OR and a surgeon to fix it.
Okay. Now, I imagine things like the lethal triad are also going to come biting you if he's colder than he needs to be, if he's acidotic, et cetera, et cetera.
Yeah. I mean, hemorrhage is hemorrhage, right? So, and bleeding is bleeding. So, if that's the situation you find yourself in with a hemothorax and not a pneumothorax, then all of those, optimize every point on the lethal diamond that you can, because you only have so much blood. So controlling all those other factors that can either improve your ability to coagulate or worsen it, becomes super important.
Perfect. So, if you had to give, young dentists some advice, other than pick a different profession, when it comes to chest trauma, just shy of tension, what advice would you give?
Know what can go wrong. Know the various serious complications of chest trauma. To include pneumothorax, to include bleeding that can cause a hemothorax, as well as hemorrhagic shock, ARDS development, pulmonary edema development. It's kind of be aware of all of those, and then just be very vigilant, because sometimes chest trauma can present you with a fast moving train of instability, and then it's pretty obvious, at least once you figure out whether you're dealing with air or blood or both. But sometimes it's a slow moving train that gathers speed as the damage to the lungs worsens over time, as swelling from contusion and inflammation cause ARDS.
All right. Perfect.
And then I guess one last thing too, if you're faced with a trauma patient who is getting worse because they've got other mechanisms like pulmonary edema, contusion, or ARDS, or all of the above, and they have a pneumothorax, that's probably a patient even if they're stable with that pneumothorax, you may wind up having to put a chest tube in, because in order to oxygenate their lung injury enough, you're going to have to put so much ventilator pressure in that you're going to worsen the pneumothorax, and then you're going to have to vent it.
Okay. Yep. That makes
sense.
It does make sense. Well, I got to be honest, that was all my questions.
Awesome. That was a good conversation.
Yeah, I think so.
Awesome.
Well,
all right. I think dinner's ready. If that's good enough material for this one.
I think it is. Thank you, Doug.
That's excellent. Right. You're welcome, Dennis. And let's do that cardiology one sometime. That'll be fun.
Yep. I'm looking forward to it. That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.